Okay, welcome everyone. Thank you so much for joining us today. My name is Maggie Cameron, for those of you that don't know me. I am the Director of Development and Communications for the EHE Foundation, and I'm also a patient, so I get a lot of benefit out of these webinars. Before we get started, I'd like to share just a few housekeeping items. This session is being recorded, so if you find you need to leave before it's over, that's no problem. We will post the recording to our website and YouTube channel soon. And I want to also call your attention to your Zoom toolbar down at the bottom of your screen there. There is a Q&A button down there. Please use that to submit any questions during the presentation. So if you think of anything along the way, just type it in that Q&A and we'll be sure that to try to get to answer that before the end of the session. We want to remind all of our participants that the EHE Foundation does not provide medical advice. The information provided here is for your information only, and we do encourage you to contact your own healthcare provider for any specific questions about your health. Okay, so with that, I think we're ready to get started. I'd like to welcome Denise Robinson. She is the EHE Foundation's Executive Director and Director of Research. Welcome, Denise. There she is.
So welcome everybody. Thanks for making time to be here today or tonight, this afternoon, wherever you are. Dr. Loggers is on the West Coast, so it's earlier in her day and I'm on the East Coast. I have the pleasure of introducing Dr. Elizabeth Loggers. She is a medical oncologist who is an active researcher. She is the medical director of palliative care at Hutch Cancer Center in Seattle, Washington. And she specializes in the treatment of sarcoma. She works to identify novel treatments. And as well, she's an expert in managing treatment and cancer-related symptoms and supporting patients' quality of life and working in her research to improve quality of life. I had the opportunity to hear Dr. Loggers talk about palliative care last year, and her words really transformed my personal perception of palliative care. And I really hope that tonight you'll find benefit and strength in her talk. As Maggie mentioned, there's a QA toolbar down in the bottom of your screen, I think, or if you're on a phone, it's somewhere on there. And after the presentation, if you have questions, drop your questions in the chat or in the Q&A anytime, and we'll talk through those at the end, and we'll make this interactive. So please help me welcome Dr. Loggers. Thank you. Let's see. I think she can come on. Okay, there you are. All right.
Well, hello, everyone. Thank you so much for having me here. I really appreciate this opportunity to speak with you about understanding palliative care and extra layer of support in your care journey. I'm going to go ahead and get started by sharing my screen. So please bear with me and let me know if you're not seeing my slides. Are y'all seeing the slides?
We see you. Yep.
Perfect.
I'm going to say yes, and then I'm going back to tape again.
Thank you, Denise, for that confirmation. Well, that was such a kind introduction and captured just, I think, beautifully my interest in all of this comes as an active medical oncologist who treats individuals with EHE and who really was very much aware that this is a difficult time in life for many people and the people they love. And I wanted to make sure that I could do everything, not just in treating the cancer, but also in supporting the individual. So I'm going to go ahead and just acknowledge that I don't have any disclosures for this particular talk. I won't be talking about any active treatments or anything like that. So we're good there. This is, oh my, sorry. This is just kind of an outline of what we're going to talk about. This is a short presentation, so there should be plenty of time to answer questions at the end. Just feel free to put those questions in the question and answer section. So I will describe what palliative care is and how it differs from hospice and how you can get palliative care, and also give you just some concrete examples of how we help people when we're working in that palliative care role. Um, I want to just start though by talking a little bit first about the complexity of EHE. You all know this because you live this all the time and are, out informing yourself and your community about this rare disease. But, as you know, epithelioid hemangioendothelioma is an ultra rare vascular sarcoma with really unique features. It's characterized by what I would call an unpredictable, sometimes indolent, but sometimes not, course that can be really highly variable and has a lot to do with where does it reside in your body, where does it start from. So I really wanted to start off by presenting some data that I hope you've seen before. This is work primarily from our colleagues from the Netherlands who are also interested in quality of life and symptoms, particularly for EHE. This is a study that was conducted in 2018 among 115 individuals with EHE from 20 countries, primarily from the UK, the United States, and Australia. And the EHE foundations in each of these countries were involved. And so I apologize for those of you who've seen it before, but I think it's so important to just kind of ground ourselves in what is known about this ultra rare cancer. These folks that participated in this study were recruited via Facebook and via emails through their foundations. And what we learned is from this study is that the average age of folks who participated was 47, but it ranged from 17 to 81 years old. Most were female, about 80%, and they lived about 50% in the United States. And 80% of them were not on active treatment, and about the same amount had no disease or were in that indolent or stable phase of their condition. But 87% of people reported one or more symptoms. And what you're looking at here are the individuals who had what were called in this work high symptom clusters. So they had more symptoms than others. And what we learned is that the people who had more symptoms tended to have disease that was located in their bones or in their pleura. And the comparison in this graph or in this figure that you're looking at is to what they called a normative population. So generally that's a population of healthy people who do not have any cancer. And what the authors were trying to show is how different the quality of life and the symptoms and things are. And you can see where these like asterisks are on top of the bar chart. It's basically saying that this was statistically significant differences between a healthy population and these individuals with EHE who had high symptoms in terms of that particular thing, like global quality of life or physical functioning, role functioning, which is like, how are you able to act in your role, for example, as a spouse, as an employee, as a sister, or a husband. And so these individuals were expressing that their experience of EHE had really significant impacts on really all aspects of their lives. Insomnia, fatigue, and pain were some of the most commonly reported symptoms. And these individuals, those with high symptom burdens, reported 25 to 30 points lower in their scores than these folks. And these symptoms had translated to a worse quality of life. So we know that if you have EHE and you're having symptoms, this is serious business and it affects you. And these same authors went on to talk about the supportive care needs of people with EHE. And this just shows you on the most right column how frequent the concern was. And then that larger, most prevalent needs column is basically telling you what the need was. And they separated them based on the survey that they used into different categories. But you can see that very most prevalent concern is uncertainty about the future and learning to feel in control of our situation, fears about the cancer spreading, and worry about the results of your treatment are basically beyond your control. So the psychological needs and support were greatest in those 115 people who participated in this survey. But there were other things too. They needed to know how they were doing and have someone to talk to, someone to help address the symptoms, including lack of energy, pain, not being able to, engage in life in the way that you were used to. Um, and potentially having effects on sexuality and your sexual drive and feelings. So again, I present this because I want you to know that people are doing research in ultra rare cancers that has to do with quality of life, symptoms, and the support that would be beneficial, and that these findings just speak to how important it is to have extra support when you have a cancer diagnosis or any serious illness. And then I want to just draw a really direct line between these needs and the role that palliative care can play. Because I would argue that all of these things are exactly the kind of things that palliative care providers want to help with. They really want to get to know you, and they want to figure out what you're experiencing and how they can make that better. And that might be with you, but it might also be with your family, with your children or your grandchildren, or other important people in your life, where the goal of palliative care is to support them too at the same time that we're trying to improve quality of life and symptoms for the individual with the serious illness. So, I'm going to dive further into what is palliative care now, but I hope that that gives some context and some real evidence around why this could be important and how it could be helpful. So, when you're living with a serious illness, like I said, a lot's going on, and palliative care is that extra layer of support. And like I said, we do that by getting to know you very well. So often our visits are just us asking a lot of questions and listening very carefully to what you say and to what your partner or your child or whomever might be joining you on that visit says as well. And we are trying to address all concerns, whatever they are. And so when people ask, well, what is it exactly? I say, well, it's whatever it is that you need, right? Often, if a first visit is primarily about pain, I might spend an entire hour just evaluating pain and all the other things that are going on in the hopes of coming up with the very best plan for pain that I can that takes into account the fact that you might be tired, that you might not be sleeping well, that your pain might have many different sources in your own body, and that the treatments might be therefore, varied. So again, uh, we're trying to specialize our care to and individualize it to you. Palliative care providers receive additional training, so they can be from any particular background now. So you could have a palliative care provider who is trained as a surgeon, or like myself, as a medical oncologist or an internist, family medicine doc. But they take an extra year of medical training to focus specifically on communication, symptom management, and the challenges surrounding serious illness. They also are trained side by side with other individuals who may not be going into palliative care, but may be going actually into hospice care. So we have the similar care, but we are different, and I'll show that in a later slide. My apologies here. So we already mentioned, symptom management and how we try to individualize this. We also really try to focus on what I call polypharmacy, which is, often docs, we just kind of keep adding pills and adding pills and adding pills, and we don't pay a lot of attention to the pill burden that people have, or how complex the scheduling is, or the risk of interactions and that kind of thing. So palliative care providers really try to think about that, and they try to reduce the number of pills, focus on a logical and rational schedule, and identify other ways of treating things that maybe aren't even pill-based. We also try to keep people out of the emergency department and at home as much as possible, because we know that most of us want that. Most of us don't want to be in the hospital or in the clinic if we can help it. We also acknowledge that with serious illness, it's often the case that people are having psychological and what I would call existential distress. This really calls out for people um, their own mortality, even when they're not, going to die, but it just brings up these questions. And it also makes us wonder, like, how do I want to spend my time? What is important to me now? And these are all really common questions that people experience. It's also there's also a phenomenon that I call demoralization, where this is not depression; it's something very different. When people are depressed, they often sleep more. They don't enjoy things. They can't get activated. But people who are demoralized may still very much love their activities, love their family, but they often feel somewhat trapped by their illness, sometimes angry about it, and its effects on their lives, and can feel like they don't know what's important in terms of their um, what they are giving to the world. Where do they fit in the world? And so demoralization actually requires different interventions than depression or anxiety. And so we really try to think carefully about these things. We involve social workers, psychologists, and psychiatrists, but often these are very normal experiences, very normal thoughts, and they don't necessarily require medications, but more just education, normalization, and then strategies. And so we try to do that. We also try to make sure people are connected to other supportive care services that might also help them tremendously in this experience. That could be nutrition or spiritual health, rehabilitation services like physical therapy, lymphedema management, occupational therapy, and integrative strategies. Again, like I said, we don't think that pills are, the end all be all. There may be other ways of addressing some of the concerns you have, and that is our goal as well. And so for a real example, we know that there's very good data for acupuncture for certain things like pain and nausea, and increasing information about the role of acupuncture in things like peripheral neuropathy and hot flashes. So we want to investigate whether you're interested in that, and get you to those practitioners if that's appropriate for you. We also think about things like imagery, meditation, progressive relaxation, and things like that. But I think what we do more than most docs, and more than the medical community in general, is we really focus on being clear, kind, consistent communicators. And I just can't stress that enough. People need to trust their doctors, to trust the advice that they're getting, when they have a serious illness, more than ever before. They also need what I call anticipatory guidance, which means, many people have never had a serious illness before. Um, they may not have had friends or family who have a serious illness, so they've not been in the situation before. And palliative care providers do this all the time, day in and day out. And so they have usually a very good sense of what you might need to consider as time goes on, especially if your illness gets worse. And so we try to get to know patients and families very well, and try to think in advance for them. What could be really important for you to do now that might make this journey easier? And that, of course, is also very personalized. So I can't tell you what exactly it is because it always varies, but it could be things like advanced care planning documents, durable power of attorney, could be helping you think about, other aspects of your personal life like that. Um, and we also want to empower you as the patient and as the caregiver and the family, uh, that what you want does matter. And as long as you're well informed and thinking clearly, your choices should drive everything we do. And there's no wrong or right answer. There's just the answer that's right for you. And so we often will spend a lot of time reassuring people that, um, you know, uh, whatever their choice is, as long as they've got the right information, then there's nothing that we've missed. that they can exert that desire of their own. Of course, it can't be, medically inappropriate or dangerous, but for example, being honest with your doctor and saying, this treatment is just too toxic. I don't want to do this. I'd be interested in something else if it can be less toxic. For example, sometimes is a conversation that people really need support to have. We know that sometimes people can feel like they're letting down their team or their family when they're just feeling quite fatigued and overwhelmed by a treatment. And so we try to help people in those situations. The more you speak up, we believe the better your health and your healthcare can be, because it'll be more appropriate, for you. So I do want to just spend 1 second talking about the differences between palliative care and hospice, because I know that there was already a question about this and it can be very confusing, especially because we are all trained in similar techniques. We are trained together, and then we decide whether we're going to work in a palliative care environment or in a hospice environment, or sometimes people will move seamlessly between them, working in different kinds of jobs. But basically, the fundamental difference is that palliative care can be provided at any time during a serious illness. And I work with people who are destined to be treated for their cancer and survive it, as well as people who might actually die from their serious illness. The point is, I get involved anytime along that trajectory, and I can come in and out of people's lives as they need me as a palliative care provider. In general, in the United States, hospice has been designed and intended for people who are in the last 6 months of their life, we think, based on doctor's best guesstimate, right? With respect to hospice, some insurers will allow people to actually join hospice earlier and sometimes even concurrently with their treatment. It really depends on the particular insurer. Specifically, I mean commercial insurers. For Medicare, it's always the last 6 months of life, but for other things, it could potentially be different depending upon the policy that you have. So therefore, people who are joining hospice, are in a more narrow time in their lives. And at that point, they should not be receiving treatments to address their serious illness or prolong life. Really, the goal of hospice is to promote comfort and quality of life. And most hospice care is provided in the home, and that hands-on care, day-to-day care, is provided by friends or family in general. Whereas palliative care is typically the kind of advice that you would receive either in the clinic or in the hospital. It's not that palliative care providers don't ever come to the home, it's just much less likely, much less common. In hospice, the person who's coming to visit you in your home tends to be a nurse, a social worker, a chaplain, a volunteer, sometimes a doctor, but their visits tend to be less common. And then coverage for palliative care is whatever your insurance is for in general, for doctor visits or nurse practitioner visits. Same is true of any prescribed therapy. So if I prescribe a medication as a palliative care provider, it's covered based on whatever your insurance coverage is for medicines. In the United States, though, if you're on hospice as part of the Medicare hospice benefit, your medications are covered by the hospice. Same with like your durable medical equipment or bandages or bedside commode, that kind of thing. What's not covered in hospice is room and board. So when people aren't when they're on hospice, when they're receiving hospice care but they're not living in their own home, the individual is still responsible for that time that they might spend, let's say, in a nursing home or an adult family home or something like that. And often people might hire additional caregiver services if their family and friends can't provide, all of the hands-on care that they might need. There are some what are called residential hospices where people actually do go to stay, but most of the time that's used when people's symptoms are really significant or severe and can't be controlled in the home. And the goal of the hospice is to get you back home once those things can be addressed. So it's not that you can't die in a hospice facility. It's just not as common. Most of the time, those kinds of stays are going to be time limited, and then hopefully people can get back out to the home. And home in this context is wherever you're living or wherever you usually live, even if that is a facility. So you might need a referral to palliative care, either because your insurance requires it or the palliative care team requires it. I can tell you that for palliative care at Fred Hutch, we don't require a referral. Any individual can refer themselves to palliative care, or their family member can refer them, and we'll see them whether or not their doctor uh, recommended they receive palliative care or not. And we do this because we know that people often just want to talk, to us, and don't want to be burdened with having to, seek out a referral or that kind of thing. But you do have to be a Fred Hutch, a person receiving care from Fred Hutch, and right now we're limited to people who are in active treatment or who are transitioning to a hospice like care situation. So anyone, though, can refer themselves to hospice. The catch, though, is that you have to be determined to be eligible for hospice, and that eligibility is usually determined by a hospice medical director and usually one other doctor. Most of the time, that other doctor is going to be, for example, for people with EHE, their oncologist or their nurse practitioner or physician assistant. You can inquire about hospice and get information about hospice without actually signing up. But when you sign up, you have to have two doctors who say that, yes, it's a reasonable guess that you might have 6 months or less due to your serious illness. So I hope that information helps. And I just now want to share a couple of patient stories and quotes that kind of illustrate palliative care. So this is a compilation of some different patients I've had, but basically, John was a patient who had ongoing nausea and vomiting and really had received a lot of different medications, Senna and Miralax and lactulose and something for nausea and that kind of thing, and really didn't seem to be responding to any of that. It seemed like they were still nauseous and vomiting. And so was referred to us for help. And while discussing their care, we realized that John had daily bowel movements previously, and now was still having daily bowel movements, but they were very small, never really felt like he went completely to the bathroom. And so we looked at his CT scans and realized that there was just a ton of stool in there on the imaging. And, radiologists don't always comment on these kinds of things, especially in people who have a known cancer diagnosis, because that's not what they're focused on, right? They're focused on what's going on with the cancer and are they responding to their treatment. But once we realized, oh, you're constipated and the constipation is what's making you nauseous and vomiting, then we can actually resolve that fully and get you feeling better. And often, we find that if we resolve constipation, not only does the nausea and the vomiting get better, but the appetite gets better, energy level gets better, abdominal pain improves. It's kind of this multifactorial thing. So I jokingly tell people we talk a lot about people's bowels in palliative care because we just know how important it is. And these are just some patient quotes, and it basically reflects what we hear all the time, which is, um, uh, this kind of additional layer of support that doesn't take the place of your primary oncology team at all. We work alongside the oncology team. We never take over, treatment decisions or anything like that. We're just there to kind of walk beside you and help you and advocate for you. That most people are really very grateful for our input and often tell us they wish that they'd seen us earlier, that they hadn't been scared of it, that they had just jumped in sooner and had gotten the help that they needed. So again, I just want to encourage you to, if you think that kind of extra layer of support would be helpful to you, what's important is that you do ask your team your oncology team, do you have palliative care? Does this institution have palliative care? Especially in the ambulatory setting, like in an outpatient clinic or potentially a home-based palliative care scenario. If they don't, then I would recommend that you consider asking your insurance provider. If it's something other than Medicare, obviously Medicare, you might, there's not necessarily someone specific to ask, but if it's a commercial insurer, sometimes they will tell you who is in your network, so to speak, for palliative care, and will help you figure out if you can actually get access to them, even if you're not getting, specifically care, within that network of larger network that they sometimes might be part of. You can also just Google. So there are websites such as getpalliativecare.org that can help you figure out if there's palliative care in your area, or just simply Googling, palliative care and wherever whatever city you're in, to find out who your palliative care providers are. So I hope this has given you, this brief overview has kind of given you a better sense of what palliative care is, and how we are different and similar to hospice. And I'm happy to take any questions. Oh, Denise, I can't hear you. I think you might be.
I'm on mute. I apologize. Thanks so much. That was great. I learned more listening to you, and it's just really, really, I don't know, it's reassuring. I love, you started talking about integrated care, integrating care partners, considering the whole family, the hub, around that patient, is just really, really important. And, I probably was raised thinking that palliative care and hospice were the same thing. I'm sure that in my career I've used the words interchangeably, and there are differences, and I'm glad that you explained it that way. Um, we do have a couple of questions. Um, so Maureen asked, what should a patient and family member do if they feel the oncology team is not addressing all mental health concerns at big hospitals focused on research and clinical trials, not wanting to disrupt or be disqualified from a clinical trial? So it sounds like how do you get what you want without being a troublemaker?
Yeah. Thank you for that question. I appreciate that sometimes it feels difficult to navigate these conversations, and that folks don't want to disrupt the relationship with their primary oncologist. I usually encourage people just to be very inquisitive, and to just ask questions in a very open way. Like, I wonder, are there more supports here at this organization for mental health? Or I've heard about palliative care. What do you think about that? Do you have palliative care? Just kind of, asking it as a global question, and then let the doctor kind of answer the question. And if they don't seem to readily refer, like if they don't seem to kind of say, oh, and is that something you're interested in? Would you like me to refer you? Then you could say, I'd like to explore that more. Could I get a referral? And I think usually when, I'm answering this now as a medical oncologist, when I hear that from a patient, I Jim Dandy get that order in, because I can tell that it matters to them. And so if they still aren't sort of responding to what you're requesting, I would just suggest to you that most of the time, these supportive care services will accept referrals, even without a doctor's referral. So if you inquire directly with them and say, we'd like to get this service, if they often will see you without having a referral, or if they require one, they'll often go get it for you. And then you're not the person who has to ask for it. So I would try those techniques first.
Good examples. I imagine that we can replay this recording a lot in all of our healthcare when we're talking with providers and we're asking for things. It takes a lot of courage sometimes to ask those questions, and time is tight, and you have to slip those questions in between other discussions that you're having. Very good. Thank you.
On that note, could I just mention that, like,
Yeah.
I'm always welcome to people sending a list of questions in advance or printing them and handing them to me. Then that way I can organize my thoughts quickly in an appointment and can hopefully get through the list in the amount of time that we do have, because I appreciate that. It is hard, especially if the questions are coming one at a time, and I'm not really sure which one is the most important one or how they relate to each other. So I love getting all the questions at once. Then that way I get a sense of, okay, where are the areas of concern and how can I answer these really efficiently, or potentially prioritize which ones I think are going to be most important given what I know about the patient and family, and then finding a good plan for how we can come back to the other ones if we can't get through the whole list. So I encourage people to write it all down and bring it in.
That's a
Don't be
great
shy.
tip. Yeah, no, I like that a lot. Let's see. So Sharon asked, is it typical to have a palliative care team in the hospital tell you that they're there to help you manage your meds? Never mentioning the support part of palliative care. I'm kind of taking that um, out of her comment there. So there, is it typical that they're only meds management, really?
Well, some teams function differently. Some teams are really very heavily focused on symptom management. Um, and sometimes that's an institutional specific reaction. Um, and I'll give a very specific example. So for example, at the University of Washington, we have a very robust pain service that has been in existence since, the University of Washington was founded. And so because we know that pain is so heavily addressed by different service, they have an acute and a chronic and a post-op, and at the University of Washington, we may focus more on goals of care conversations or coping and anticipatory guidance than pain, because we know that people may be getting pain management in other ways. So it does depend. But I would say that anybody, now that's practicing palliative care has also had training in communication support. And that is, part of the expectation for the profession. So if that's what you would want from your palliative care provider, you should be able to say, thank you so much for my nausea. And what I really want to talk about today is demoralization and how can I help my children through this? And they should be able to respond to that. And if they're not, then I think just like any other profession, sometimes you've got to either be more of an advocate for yourself, or you've got to find another doc or nurse practitioner or whomever who is going to address the needs that you do have.
Excellent. Thank you. Yeah. Um, what if you are a care partner of someone who has the disease and I think this is the question. This is a question that came in earlier. We asked for questions when people registered. So it says, how can I support my spouse when they don't want to engage in therapeutic support? I believe that the spouse is possibly, I'm not sure which of those is the patient, but let's just say that the whole team is not on the same page.
Yeah. And often we see this where, it could be the patient is all in for supportive services and the family members are not, or the reverse, or they are, but kind of at different times, because things can really change over time. Um, I just want to I just want to acknowledge that there are expectations, rules often about being seen. And what I mean by that specifically is that, for a doctor or a nurse practitioner to, be able to participate in a visit, they usually have to see the patient. So I know that this can really be frustrating sometimes for family members or friends that are trying to support a patient who doesn't really want to be present, especially if they're getting told, well, we can't see you then if the patient doesn't want to participate. Sometimes family members can say to or loved ones can say to the patient, hey, I get it, you are not interested, but I need this support, and this would really help me. Would you just be willing, you can put your headphones on or read a book or whatever, but would you be willing to sit in the room, in the clinic room, so that I can get the support and the information and the anticipatory guidance I need? And sometimes people will, when they realize how important it is to someone else, go ahead and do that. There are also some teams that will see family members without a patient. And so I would ask that you inquire. This is particularly common with social workers, for example, spiritual care providers, and some palliative care teams will also allow for, one-off or a limited number of visits that don't include the patient because because the institution allows it and they understand that it can be really important to get that extra support.
Interesting. Very good. Thank you. Thanks.
Yeah.
Um, so we had a question submitted earlier about referral, and you've talked about that. Um, and so there was a question, and I think you've addressed this. You mentioned palliativecare.org. The question
Get
was,
palliative care. Sorry.
get palliative care.
Get
Yes,
palliative
yes.
care.
Get palliative care. We have to publish that after this. Uh, so the question was, are palliative care specialists typically found in sarcoma or cancer reference centers? And I think that, in the United States, we refer at the foundation, we refer people to large academic teaching hospitals, medical centers, comprehensive cancer centers. Would you say that by and large, most of those centers have palliative care teams? Okay.
Yeah, yeah. The difficulty is that palliative care is not just for cancer. So we also see people with heart failure and liver transplant and all kinds of things. And so sometimes what happens is that the waiting, period to try to, you get in the queue with a referral, but perhaps you're not being seen as quickly as possible. That can sometimes be a problem. But most large centers will have palliative care for sure if you look into it.
Excellent. Thank you. Yeah, I would imagine that pain management, some of those disciplines have, it's a lot of diseases that are coming into those places. You discussed pain management, so we talked about that a little bit. And I think that you hit on this because you talked about the coordination, with the care team. The question was, does the palliative care person take over treatment, or does the palliative specialist work with my regular cancer doctor?
Yeah, exactly. We do not take over treatment in any way, shape, or form. We and we so we don't take over treatment, and we don't come up with, for example, a prognosis without either some very intimate knowledge of the disease, such as for example, I, of course, know a lot about sarcoma prognosis because I'm also a sarcoma provider, but I don't try to come up with a prognosis for a patient who has colon cancer or breast cancer. I go to the doctor who's caring for that person if we have questions about that and the family or the patient wants to know but maybe doesn't want to discuss it with their cancer doctor. They just kind of want to know and maybe talk about it with me. Um, we also generally have a conversation with the primary care team about what they do and don't want us to take over. So sometimes patients will say, I think my nausea management and stuff like that, let's leave that with the primary team. Can you guys just do my pain management? Yep, we can, because we coordinate with your team around that. So it does sometimes take a little bit more communication and conversation about what we will take on and what we won't. But it's always in service to what seems best, for the patient and family.
Excellent. Just out of curiosity, one of the questions that comes up many times in our community, there are many questions around scans. How often to scan? As you know, with the EHE, you'll have patients that have almost no change in their disease, maybe fewer symptoms, slight symptoms, and it runs the gamut, right? Do you talk with people to help them, because there's reportedly and in literature and by people that we talk to, a lot of anxiety around that. Do you talk with people as part of that, discussion with them? That must be a topic of anxiety that you hit on quite a bit, I would imagine. And
Absolutely.
can you help? You mentioned earlier that, patients get to make a lot of decisions, which is good. That also is a burden, that can also create anxiety,
Yeah.
especially in a disease like EHE, where there aren't a lot of, absolutes. There are very few, in fact, absolutes. So there are a lot of decisions to be made, and often that decision comes back to the patient, which heightens anxiety too.
Yeah. Yeah, no, I completely agree with you. Often one of the first conversations that we have when we're meeting a patient and their, extended loved ones is, what kind of information do you want, first and foremost? How do you like to communicate? Um, Everybody's different, and then, how do you like to participate in the decision making? So some people who are brave can sometimes say, I don't want to make these decisions. That's why I'm coming to you, like, and that's why I'm going to this expert in EHE. I don't want to, I'm, this is not my area of expertise. And so we try to be real clear then that, like, this person is probably going to prefer a recommendation, not just like, well, what do you think about, how often you should have scans, but probably something more specific. And they may still want to ask questions. Well, doc, why did you just choose 6 months instead of 3 or 12 or 9? And so I always try to encourage people, if they have questions about the recommendation they're given, it's still okay to ask questions, but it's okay to tell your doc, I'm here because I trust your judgment and I want your expertise. I don't want to be put in the position to have to make choices that I don't fully understand and then live with the consequences of that. Um, um, and it's okay to weigh in with the things that you do definitively know. So I always try to remind people that they know their bodies better than anyone. They're the expert in how they feel, their quality of life, those kinds of things that I can only know about if I ask questions and if I listen carefully. So if you tell me, you know, I hate the MRI machine. I don't want to be in it. It freaks me out. It's clangy and it's tight. And, I'd rather, get a CT scan any day of the week. I don't care, about any, exposures or whatever. I want that. Okay, that makes good sense. We put a big note in the file, CT scans only, avoid MRIs. We'll obviously also help people if they need support through the MRI, because sometimes that's, there might be imagery, there might be music, there might be hypnosis, there might be benzodiazepines that are needed. There's all kinds of things that we might be able to work with someone around to try to help them get through it if it's important. And then when it comes to scan anxiety, I tell people absolutely that's real. Absolutely, because we know that recurrence anxiety is real, right? Like, the scan is just one part of the bigger question that's at play, which is what's going on with my cancer. So we will actively talk with people about, how this affects them. What do they notice? When does it come on? How does it present itself? Because it can present itself sometimes in others as irritability or anger or insomnia in the days before, or new pains that they notice that, that I was fine, 2 weeks ago. Why am I now hurting? That kind of thing. And kind of talk them through, like, what's useful in this, in terms of helping you cope more in in the most positive way possible. So it's real, and no, we try to normalize that.
I don't think that I have ever heard of recurrence anxiety. I don't know how I might have missed that, but wow, really, really, it's not lumped in, it shouldn't be lumped in with scanxiety. It's a different thing, I think.
It is a very different thing, right? Because this individual could have no anxiety in other situations. They could be a very social person with no anxiety around meeting people. They might not, separate from the scans, even think about their cancer or worry about it. It's only in that context that the anxiety and the worry comes up, and it makes perfect sense.
Yeah.
That of course it would be nerve-wracking, when you don't know what the answer will be. So yeah, we try to reassure people that it's completely normal. We see it a lot, and there are active studies trying to understand, how to cope with that. And
Excellent. This has been really, really great. As I said, I learned something new. I hope that everybody who joined tonight really benefited in some way. The whole session it was recorded, so it'll be posted to our website, and give us a week or two to get this out, and then you can replay it. You can rewind Dr. Lager's suggestions on how to approach different challenges that you might be having, and hopefully those will be helpful, and share that around. Thanks for joining. Thank you, Dr. Lagers. Really, we really appreciate you're busy. Everybody who's here and everybody who watches you later is going to want to come to see you, not just to come to Seattle, but really just to see you. You're very compassionate and an expert, and we really appreciate your time given to this community. And I think that is it. Thank you, everybody. Thanks for the questions. Loved seeing the thumbs up coming along. I hope that I know you touched some people through this talk, so it's really great. Thank you so much. We really appreciate it. Thanks, everybody. Have a good night.